Chapter 10 of Hagen Answered, the Gallbladder and the Biliary System, Lecture 1. So anatomy of the biliary system is going to include the gallbladder, the right and left hepatic ducts, the common hepatic duct, the common bile duct, and the cystic duct. This is one of the easier anatomy lessons that we're going to do. So I want you to picture the liver sitting up here, right? Gallbladder sits inferior to the liver in that little sort of depression, right, on the inferior side of the liver. And what we're going to have is the right hepatic duct draining the right lobe, the left hepatic duct draining the left lobe. Remember that the hepatic ducts are part of the portal triad. Wherever you're going to find a portal vein, you're going to find a hepatic duct and a hepatic artery. They're going to combine here just above the porta hepatis and form the common hepatic duct. The common hepatic duct is going to run through that porta hepatis. It's going to join the cystic duct, which connects the gallbladder to the common bile duct. So the cystic duct and the common hepatic duct are going to come together to form the common bile duct. It's going to run inferior, so vertical, oblique, down. It's going to go behind the pancreatic head to join the pancreatic duct. And once it does that at the pancreatic head, it's going to enter the duodenum through the ampulla of Vater and the sphincter of Oddi. The gallbladder itself is formed of a fundus, a body, and a neck. Inside there's on the inside it's lined with a mucosa that has a bunch of little folds in it. And then here in the cystic duct, we also want to talk about the valves of Heister. I'm pretty sure I've got a slide on that in a little bit, so we're going to keep moving forward. Okay, so let's just do a quick recap of what we just learned. Those hepatic ducts, the right and the left one, are going to combine to form the common hepatic duct. The common hepatic duct is going to run parallel with the portal vein. The common hepatic duct is approximately 4 millimeters in diameter. If it's above the cystic duct, it's called the common hepatic duct. If it's below the cystic duct, it's called the common bile duct, because that's where the hepatic duct and the cystic duct meet to form the common bile duct. The common bile duct can be up to 6 millimeters in diameter. It's going to be larger in patients as they age. You can use as a rule of thumb approximately 1 millimeter in diameter increase per decade. So we go from about 3 millimeters in our 30s to up to 6 millimeters in our 60s and 70s. Once we hit 70, even if it's a little larger than that, up to 10 millimeters is not unusual. It's going to join the pancreatic duct shortly before entering the ampulla of Vater through the sphincter of Oddi. The ampulla of Vater is the opening into the duodenum. The cystic duct connects the gallbladder neck to the common hepatic duct. And what you want to remember about those is they are tortuous. They're all kind of twisty in there, that cystic duct in particular. Now the gallbladder itself is made up of a fundus, a body, and a neck. The fundus is the lowermost part and it hangs below the liver margin. The body is going to project upward, leftward, and posterior. Usually the fundus is the most anterior part of the gallbladder as well. The neck is continuous with the cystic duct and can also be sort of serpentine in nature. Inside that neck and that cystic duct, you're going to find Heister's valves. And then we can have some variations. Hartmann's pouch is a little outpouching of the neck. A Phrygian cap is a folding over of the fundus. And then there can be septations. They can be partial septations or complete septations. You can also have duplications of the gallbladder. So you might actually have two gallbladders. One that is maybe a full gallbladder, the other one may be just a partial or a vestigial gallbladder, or it could be a full functioning gallbladder as well. Typically it's going to be about 3 centimeters in diameter, 7 to 10 centimeters in length, and the wall thickness should be less than 3 millimeters. You'll recall we're going to measure the wall thickness in transverse. So here we go, putting it all together, right? We've got that gallbladder, fundus, body, neck, Okay, this one is our variation with the Hartmann's pouch. You can see that little outpouching right at the neck. This is a spot where gallstones really like to get stuck if they're nice and tiny. This is where they're going to obstruct the gallbladder and keep it from squeezing bile into that cystic duct. The cystic duct is the one that I said was tortuous. You can see it's got all these little Heister's valves in it. And then the cystic duct meets that common hepatic duct to form the common bile duct. Common bile duct is going to go behind that pancreatic head, meet the pancreatic duct, and the two of them are going to join and enter the duodenum through the ampulla of Vater. Here's what our septations are going to look like. Not always. There can be a single septation or there can be multiple septations. And then a Phrygian cap, remember we said, was a folding over of the fundus of the gallbladder. Here you can see that duplicated gallbladder that we talked about earlier. We've got a full gallbladder over here and then a sort of a vestigial gallbladder on this side. So what does it do? Well, the gallbladder's job is to serve as a reservoir for bile. It's where we're going to store the bile until we need it. Functions of the bile are for transportation and regulation. The gallbladder concentrates the bile and then squeezes it out, introduces it to the duodenum to help digest our food. So it's going to, when we eat, that's when the gallbladder is going to contract, and it's going to dump bile into the duodenum to aid in the digestion, the emulsification of fats and the digestion of food. Now, you might be wondering what happens after cholecystectomy, after the removal of the gallbladder. So the gallbladder is a reservoir, and it does help concentrate the bile. However, we can totally live without it. The liver is going to continually produce bile, which is going to get dumped into that biliary system, that intrahepatic biliary system, which is made up of the hepatic ducts. The right and left duct are still going to come together. It's going to still form the common bile duct, but that bile is going to run continuously through that common bile duct and into the duodenum. So oftentimes after cholecystectomy, patients will have some difficulty with things like urgency and diarrhea. I should also mention that after cholecystectomy, that common bile duct tends to dilate. So it is not uncommon to see it as be as wide in diameter as up to 10 millimeters. Okay, so let's talk about how we're going to image the gallbladder and the common bile duct. We want, in supine, we're going to want sagittal. We'll want sagittal with color. We're going to take transverse images and measure the wall. Then we're going to roll the patient onto their left lateral decubital side, and we're going to take sagittal and transverse images again. We're going to catch a picture of the common bile duct using color Doppler to prove it is a duct and not a vessel. We're going to measure the common bile duct, and we will be done. Now you might be asking, how do we prep our patient? The answer is NPO for 6 to 8 hours. All right, those sagittal views in supine. We want to sweep through the gallbladder, lateral to medial. Remember, the gallbladder has a variable lie. So when we say sagittal, we want to be along the length of the organ, along the length, the long axis of the gallbladder. We want a picture sorted to the lateral. We want a mid picture that includes the neck, the body, and the fundus. We're going to put color Doppler on that mid picture and look for hyperemia of the gallbladder wall. And then we're going to turn the color Doppler off and get a grayscale of the medial part of the gallbladder. So here's just some varying images of the gallbladder in sagittal to prove that sort of variable lie and also the differences in the shapes. So you can see here we've got a pretty nice oblong sort of typical pear shape to the gallbladder. Got the fundus up here, body and neck, so this is a mid picture. We got everything we need in here. Up here we've got a Phrygian cap. See that folding over the fundus with that little bit of tissue right there that proves that it is folded over on itself. Then we got the body of the gallbladder, and then down here we've got the neck, and we can see that there's another little sort of serpentine shape to that neck. This may even be a septation, but I really don't think it is. Down here we can see that The whole gallbladder itself can be sort of S-shaped or even sort of spiral. So the gallbladder can have a number of different lies and a number of different shapes to it. Once we have our sagittal images, we're going to turn transverse on the gallbladder. Transverse is just cross-sectional. The gallbladder should be circular. And again, because of that variable lie, you may not be transverse on your patient when you're transverse on the gallbladder. You want pictures of the neck, the body. You want to measure the wall in the anterior part where it's perpendicular to the sound beam. And you want to get a picture of the fundus. Now that we've done all that, we're going to roll our patient onto their left lateral decubital side, and we are going to take those same images again. In sagittal, we want a lateral, a mid, and a medial. If you've proven there are no stones, you can take a single representative image in the mid. And the same in transverse, you want a neck, a body, and fundus. If there were no stones, no pathology, a single transverse image at the level of the body is enough. You want to find the common bile duct, and you want to measure the lumen. The common bile duct is going to be near the portal vein. Between the portal vein and the gallbladder is usually a good place to look for it. Look for that hepatic artery to also be a landmark, and try to follow it all the way from the porta hepatis to the head of the pancreas. And that's it. You're done. You've concluded your imaging of the gallbladder and the biliary system, and this concludes our lecture on the anatomy and physiology and sonographic protocol for gallbladder.